Welcome to Board Pearls. This is episode 2 of 3 of the pelvic floor and anorectal disorders chapter in the colorectal and pelvic floor disorders module. This episode is the constipation phenotypes that need more than pharmacology, the defecation disorders diagnosed on anorectal manometry and balloon expulsion and treated with biofeedback, and slow transit constipation documented on a marker or capsule study, where colectomy is considered only after outlet disease is excluded. The patient in front of you has failed an adequate trial of fiber, polyethylene glycol, and stimulant laxatives. The temptation is to climb the prescription drugs, and that works if the mechanism is reduced luminal water or reduced propulsion, but it doesn't work, and sometimes makes things worse, when the mechanism is mechanical failure at the outlet. So the first decision after empiric therapy fails isn't which drug comes next, it's which phenotype the patient actually has. 3 sit inside the label. Normal transit constipation, the most common, usually responding to empiric therapy, slow transit constipation from reduced colonic propulsion, and defecatory disorders from failed coordination at the outlet. They overlap because a patient with outlet dysfunction who retains stool for years develops secondary slow transit, and a patient with primary slow transit develops secondary outlet problems from chronic straining, so the workup is built to detect both mechanisms in the right order. Dyssynergic defecation is the dominant defecatory disorder, and the mechanism makes the rest of the section make sense. Normal defecation requires the puborectalis and external sphincter to relax, while the abdominal wall pushes, which opens the anorectal angle and lowers anal pressure, so stool exits. But in dyssynergia, those muscles fail to relax and may paradoxically contract during the push, so the angle stays acute and the anal pressure rises, and the colon can be propelling stool perfectly well while the patient still can't evacuate because the outlet is closed against itself, a pattern that's partly a learned behavior. Why this matters is the next move. If the lesion is at the outlet, more laxative doesn't fix it. It just produces more urgency and overflow around a still closed sphincter, so the patient who started with constipation now has urgency, soiling, and sometimes frank incontinence, escalated through osmotic to secretagogue to prokinetic, and getting worse because the mechanism was misread. The bedside clue that pushes you to test is the rectal exam during a simulated push. Ask the patient to bear down, and in normal coordination you feel the canal relax and the perineum descend, while in dyssynergia you feel the sphincter tighten against your finger or fail to relax, which is imperfect but raises the pretest probability enough to send for objective testing. The balloon expulsion test is a screening study. A rectal balloon is inflated with 50 milliliters of warm water and the patient tries to expel it while seated in privacy, and failure to expel within 60 seconds is abnormal and supports a defecatory disorder, with the current framework anchoring that 1-minute threshold. It's cheap and portable and expected as the first-line screen, so a normal result pushes toward transit testing while an abnormal one pushes toward manometry and defecography. Anorectal manometry is the diagnostic anchor, and its 4 parameters are testable. Resting pressure reflects the internal sphincter's smooth muscle tone. Squeeze pressure reflects the external sphincter and puborectalis skeletal muscle. The push maneuver tests the coordination between abdominal effort and anal relaxation, where the dyssynergic pattern is a paradoxical rise in anal pressure during the push instead of the expected drop. And the rectoanal inhibitory reflex is the reflexive relaxation of the internal sphincter when the rectum is distended. So the favorite adult vignette is lifelong. Rectal sensation thresholds round out the panel, with reduced sensation suggesting a megarectum, and increased sensation suggesting the visceral hypersensitivity that drives urgency rather than constipation. Defecography is the functional imaging that visualizes the act of defecation, identifying dyssynergia as failure of the angle to open and persistent puborectalis indentation during the push, and also revealing structural lesions hiding behind the constipation label, a rectocele trapping stool, an enterocele, intussusception, or prolapse, with Mr. Defecography the radiation-free alternative that shows the whole pelvic floor. The diagnostic criterion the boards expect is that manometry alone isn't enough. The framework requires at least 2 of 3 positive studies among manometry, defecography, and balloon expulsion before the diagnosis is made, because a paradoxical contraction on manometry without an abnormal balloon expulsion is too soft, since the catheter itself can provoke artifactual activity. So 2 of 3 is the floor. Once the diagnosis is in hand, biofeedback is the treatment, using manometry probes to display the patient's own anal pressure in real time, while a therapist coaches them to relax the puborectalis and external sphincter while pushing with the abdomen, so the patient sees the pressure curve and learns to drive it down rather than up. over a course of several sessions, with response rates well above what laxatives achieve in this population and durable benefit. So the favored vignette is the patient with refractory constipation, a paradoxical contraction on manometry, an abnormal balloon expulsion, and impaired evacuation on defecography who has failed osmotic and fiber therapy, where the answer is biofeedback, not another osmotic or a secretagogue or a prokinetic, because the mechanism is at the outlet and biofeedback retrains the outlet, while conversely biofeedback doesn't help slow transit without dyssynergia, since that lesion isn't mechanical at the outlet. The patient who completes biofeedback without improvement and still has paradoxical contraction is uncommon, and the next step isn't to repeat manometry endlessly or send for surgery, it's to confirm adherence to the home practice, consider a second course at a high-volume center, and reassess for missed contributors, since botulinum toxin has mixed results, and surgery for dyssynergia isn't generally offered because the disorder is functional, not structural. Sequencing matters. Empiric therapy, then rectal exam, then balloon expulsion is the screen, with manometry and defecography confirming when the balloon expulsion is abnormal, biofeedback following when the diagnosis lands, and transit testing only after a defecatory disorder is excluded. The reason for that order is the central pitfall of the chapter. Unrecognized outlet dysfunction falsifies the transit study because a patient with primary outlet obstruction retains stool throughout the colon, and the marker study reads as slow transit, sending the patient down the surgical path, and operating on that patient produces incontinence because the outlet is still obstructed with less colon to absorb water. So outlet disease has to be excluded before transit testing is even ordered. That brings the work up to slow transit constipation, which emerges after a defecatory disorder has been ruled out, and the patient still has infrequent movements and refractory symptoms. The mechanism is reduced colonic propulsion, with fewer high-amplitude contractions and a blunted response to meals and stimulants. And the histologic correlate in severe surgical specimens, sometimes called colonic inertia, is reduced pacemaker cells and enteric neurons, though the histology is research grade and doesn't enter the clinical workup, which is the transit study. The radiopaque marker study is first line. The patient swallows a capsule of 24 markers, abstains from laxatives, and gets a plain film on day 5, with retention of more than 5 markers, more than a fifth, indicating slow transit. The pattern of retention is the part to know. Markers scattered throughout the colon suggest inertia with reduced propulsion everywhere, while markers clustered in the rectosigmoid suggest outlet dysfunction, the film telling you to go back and re-examine for dyssynergia. The wireless motility capsule is the alternative capturing the whole gut in one study, reporting gastric, small bowel, colonic, and whole gut transit separately, and its advantage is that when slow colonic transit coexists with gastroparesis or small bowel dysmotility, it detects both at once. So the favored vignette is the capsule showing delayed colonic transit plus delayed gastric emptying and prolonged small bowel transit, which is generalized dysmotility, not isolated slow transit, and the treatment direction changes because colectomy and generalized dysmotility. Treatment of confirmed slow transit begins with optimizing medical therapy, failing an adequate trial of fiber, osmotic and stimulant laxatives, and the prescription drugs before surgery enters the conversation, with prucalopride the most mechanism targeted because it stimulates the high-amplitude contractions that are deficient, and the secretagogues added or rotated, with combinations sometimes used in refractory disease, and scheduled or antegrade continence enemas an option in selected patients. Subtotal colectomy with ileorectal anastomosis is the surgical option, and the boards expect the indication criteria precisely: severe, disabling, intractable symptoms unresponsive to all medical therapy, objectively confirmed slow colonic transit on a marker study, and a defecatory disorder excluded by manometry and balloon expulsion, each criteria necessary, with the third being where the chapter has been pointing the whole time, because operating on unrecognized dyssynergia produces incontinence and fails to relieve symptoms. The disqualifying features matter as much as the inclusion criteria: prominent abdominal pain, which often persists after surgery leaving the patient no better off, evidence of generalized dysmotility, and chronic intestinal pseudoobstruction, each a separate vignette. And the long-term outcomes are mixed and worth knowing qualitatively, with a real reoperation rate, persistent abdominal pain in a large share, and common bloating, so the patient needs an honest preoperative conversation that frequency improves but pain often doesn't, and a second operation isn't rare. So the canonical vignette is the young woman with intractable slow transit referred for colectomy after years of refractory symptoms, where the right answer isn't to schedule the operation, but to confirm the absence of a defecatory disorder by balloon expulsion and manometry first, because the most common pitfall is operating on the patient whose dominant problem is unrecognized dyssynergia. One more testable scenario that lives in the opioid section: the advanced cancer patient on chronic opioids with refractory constipation despite laxatives, where a trainee proposes oral naltrexone for its opioid antagonism, and that's wrong because naltrexone crosses into the brain and would reverse analgesia and precipitate withdrawal. So the right answer is a peripherally acting antagonist that blocks enteric signaling without entering the brain, the central versus peripheral distinction being the test. So the way of thinking is the same in both phenotypes. Empiric therapy fails, and the first decision is which mechanism is in play, not which drug comes next. A defecatory disorder is screened with balloon expulsion, confirmed with 2 of 3 among manometry, defecography, and balloon expulsion, and treated with biofeedback. Slow transit is diagnosed with a marker or capsule study after a defecatory disorder has been excluded, and subtotal colectomy is reserved for the narrow patient with objectively confirmed inertia, failed medical therapy, no defecatory disorder, no generalized dysmotility, and no dominant pain. The pitfall in both directions is a mismatch between mechanism and treatment, and the discipline the chapter teaches is checking the outlet before you cut the colon. The next episode covers fecal incontinence and the benign anorectal disorders. Incontinence worked up with manometry plus endoanal ultrasound for sphincter integrity, with sacral neuromodulation as the favored surgical answer for refractory disease, and hemorrhoids, anal fissure, and pruritus ani anchored to the dentate line as the organizing landmark. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 2 of 3 of chapter 16, and I'll see you in the next one.